So I'll start with my involvement in sort of mental health issues and what led to my being appointed to be on this commission. So I'm the ranking Democrat on the policy committee, the health policy committee in the Senate. And so I work on health policy issues every week, week in, week out. And in 2011, our state was moving forward on the issue of autism insurance reform. We have a lot of families in the state who were experiencing incredibly high medical bills that weren't being covered by insurance because a lot of insurers were just systematically denying that care, and we didn't mandate it in the state. And so as the bills started moving through committee and we started hearing stories, just overwhelming stories of how families were literally mortgaging their homes and turning in their retirement savings, trying to pay for the care that their children needed, I just kept being struck by the point that although those families really need care and support, we have a lot of other families who have children with other mental illnesses and developmental disabilities and pervasive developmental disabilities that also need our help. And so I became sort of the champion of a full mental health parity insurance plan instead of just the autism insurance reform, and started to gather some support with a lot of allies. And my intention was never to stop the autism legislation from moving forward, but to say, if we're going to take care of some of our families, why not all of them? That just seems like a much better decision. And frankly, I couldn't imagine being the person to look a mother in the face and say, oh, your child is diagnosis is on the autism spectrum. Your health care is now covered. Your insurance has to cover it. And to another woman to say, I'm sorry, your child's anxiety, your child's depression, your child's, what other diagnosis is not covered. So actually moved it forward far enough that we got the mental health parity substitute on the board for a vote in front of the state Senate, the first time it's ever had a vote in either chamber in the nearly 20 years that people have been working on this issue, and it fell one vote short. So the governor himself came to talk to me and said, we really want to get this autism insurance done. We really feel like it's a good first step, and if we show the insurers, if we show the healthcare payers that this is not the big financial boogeyman that they think it will be, then we can come back to a real conversation on mental health. And I didn't know him very well, and I didn't really know if I could trust him. We're from different political parties. We don't always see eye to eye on things, even though he is a constituent. But he said, if you help me do this, he said, I promise you we'll come back to mental health. So I did. I took his word and I trusted him. We got the autism insurance reform done. And the next year, he formed the Mental Health and Wellness Commission and asked me if I would serve. So that's where, and to me, that was him keeping his word, that we were going to come back, that we were going to look more holistically at how we do a better job of providing mental health care and services for this population in the state. So, so the charge, he issued an executive order, created it, defined the size and the scope of what we're supposed to look at, and it is overwhelming. It is a deep and broad charge to look at really every place in state government that touches this population, and it's everything from criminal justice and the court system to all of the different programs that we run. Many of them, it sounds like you are very familiar with because you're spending your time and energy there, from programs in DHS and community health to housing through MSHDA, veterans issues, our schools, you heard a little bit about that. Literally every place in the state government that could be, could touch this community. He wanted us to look and see what barriers there were to people accessing services and what gaps existed in those services. And so we went to the first meeting, and it's a little bit now almost legendary, but it might even sound just, I don't know, cranky or spicy or something. But I went to the first meeting, and I said, this charge is big, and it's broad, and there's a lot that we have to do. And I need the answer to two questions before we can go forward. And the Lieutenant Governor, on behalf of the Governor and the administration, chairs the commission. I said, so I look him right in the eye, and I'm like, okay, this is what I need to know. If you already have a preconceived notion of what you want these recommendations to look like, if it already exists somewhere and you're looking for somebody to rubber stamp it, I'm not interested. Because I feel like what we really have to do is get out there in the community and talk to people and find out what's not working and what is working and how we can do that better. And so the commitment was absolutely, there's no preconceived notions. They committed to doing public hearings around the state. And the second was, I said, I have my career in Lansing, I started right out of my undergrad working for one of my predecessors, so I've worked in Lansing for 21 years. In my 21 years there, we've had 2 mental health commissions before. And as you heard Mark say, those 2 commissions, people put in a lot of time, people put a lot of energy into coming up with recommendations, and I'm sure they are beautifully bound somewhere on somebody's shelf, but they're really not being implemented, a lot of the recommendations people came up with. And I said, I don't want to be part of that. I only want to be part of something if we're really going to try to make a difference. And so we came up with this sort of founding set of principles. And you have the chair is the lieutenant governor, the co-chair is the director of the Department of Community Health, and then you have 4 legislators, just 6 commissioners on this commission. And it's literally the left of the left and the right of the right of both the House and Senate. So you have a really diverse set of opinions and values, I think, that people bring to the work. But we committed to each other that the only things that would end up in the recommendation were things that had unanimous support by us and that had something that was actionable in the recommendations within 1 year. So not that they can be all fully implemented, not that they can all be fully funded or fully actualized in 1 year, but some action step that can be taken on each one of them. And that then we would all commit to putting the weight of our caucus. I would use whatever power and influence and advocacy I could do to my Democratic caucus in the Senate to get their votes. Our colleagues in the Republican caucuses in the House and Senate would do the same, and that we hope we could really get some action. And so we went out and we did 6 public hearings around the state. We went up north to Traverse City and Marquette. We went to Grand Rapids, Detroit, Sanilac, and Lansing. So we had 6 public hearings as a whole commission. And we immediately realized that the governor's charge was for us to get him these recommendations by the end of the year. And it was way too much to try to all do together. So we broke up into 5 work groups, and each of us, excluding the lieutenant governor who chairs the whole commission, chaired one of the work groups. And we did another set of series of hearings and work group meetings around the state. And it was the most important and wonderful part of the whole process, because when you really heard people's stories and you asked them to tell you, don't just tell us the good stories, and especially in special education, where a lot of our teachers and administrators and parapros and family members, don't just tell me what's good, tell me what's not good, and I promise I'll redact your district's name, I won't tell anybody, it's not a blame thing. We really want to know what's not working and how we can do it better. And people were so generous with their time and so open with their stories, and it really informed every one of these recommendations. There's a real person, a real story behind each of these recommendations. And the first was, the first set of recommendations that we've moved now through the legislature was taking the phrase mental retardation and all references to the word retarded out of our state statutes. We were going to strip our state statutes of the R word. And that came out of this idea that we have to do everything we can as a commission to help reduce the stigma of mental illness and developmental disabilities and substance use disorders. And part of that is language, right? Mm-hmm. So we're going to start there. And this was a very intense, this came up in one of our meetings, in one of our public hearings, because there was a group of advocates that wanted to show the power of the word. And they stood up, and one by one, they used racial and ethnic slurs that none of us would say in our day-to-day life anymore. And they stood up and said, I'm not, fill in the blank. And the first one, and you're like, wait, what's happening here, right? They're trying to prove the point that we don't say those words anymore. And certainly if we do, they're not in polite company, and we are offended when people do. But with this population, we're still comfortable letting people say those words that are derogatory and demeaning. And so, and substance abuse, right? So we also say that. And we had real people come up and say, you can have a problem and need care following your physician's orders for a medication, using a medication that you were prescribed in the way you're supposed to take it, and still end up addicted. So you're not necessarily an abuser. And so that's going to be the second just sort of destigmatizing step we want to take in the state, is to change everywhere in our statute that we say substance abuse to substance use, because it's not necessarily abuse. And those are just small, easy steps, honestly. It's like the first little things that we can do. But we wanted to set this idea, this sort of culture, that there are things that we can do. to help work to address the issue of stigma. So our work group started their work, started meeting. Mine, the work I chaired, was called Education, Employment, and Veterans Issues, and so really dug in and had lots of folks who were generous with their time and expertise to give us advice, and all of the recommendations that you see in the commission come from that work.
And if I may, Senator Warren, on the language is powerful. This is not part of the current commissioner, but maybe down the road, in Japan and in Korea, for example, the term schizophrenia has psycho kind of connotation. They changed the name from schizophrenia to integration disorder, and there's a couple of studies that show that 20% more people accepted their diagnosis. So these are the low-hanging fruit that you're addressing, which is wonderful. Down the road, there's a lot of language issues that can be addressed in the future.
So I guess one of the other things I didn't talk about was the role that advocates played. So as you heard me mention, we did these public hearings, we did the work group meetings, and the diversity of people who came to talk to us really was very, it was very deep and broad. So we had family members, we had citizens themselves who had a diagnosis and wanted to talk about their particular struggles. We had, educators on behalf of students in special education. We had some of the professional associations, our school counselors and school psychologists and school social workers who wanted to talk about ratios and how we can do better in our schools by making sure we have more school-based mental health care professionals in schools buildings around the state. So the advocates played a role in I think helping find the the examples, the putting the face to what we were talking about, and then followed up with us as the process was going forward to make sure we had all the background that we needed. So definitely the organized advocacy groups were a big part of it, but lots of individuals just came and told their own stories.
Great. So what other aspects do you think will be implemented in relatively soon, or in process?
So one of the things that came with the recommendations was this realization that we could not do in 1 year everything that we had been charged to do. It really was bigger than we could do in a year, and it wasn't because we didn't work hard and we didn't put the time and energy in. There were just things we realized we couldn't quite. We knew we're a problem. We identified as a barrier, or identified as something we wanted to solve, but we didn't know how to do it immediately. So one example I use is, in this state, we've gotten pretty good at covering pregnancies and delivery of babies through our Medicaid program, and then we keep the babies on Medicaid. But 60 days after birth, the mothers are kicked off Medicaid. And we know that, again, with our focus, that postpartum depression, the signs of postpartum depression don't always show up in the first 60 days after delivery. And we know this is something we have to figure out, and so you'll see the recommendation in the report is to study it, to come up with some ideas about how do we expand, especially mental health care to our postpartum mothers. We just didn't know how to do it yet. The other issue was the issue of transportation. We realized that can be in this state in a lot of places. We don't have good public transit, and for folks who need to get to work and need to get to their job and need to get to treatment and need to get to medical appointments, if they don't drive, we don't have a lot of support for them in a lot of communities. And so the issue of transportation and how do we seamlessly support transportation for these folks is, again, just something that's going to take longer than a year for us to figure out. So we recommended and the governor accepted extending the commission's work for 1 more year, so 1 more calendar year. And we also want to use that time to start to implement, like I said, there's an action step for every one of these recommendations, and we want to look and start to see what the outcomes are, because we know we have to convince some of our colleagues that some of these programs take money. We need to put resources behind them. And a lot of us feel like, oh, this is the right thing to do. It's a good thing to do. But we also think there are a lot of savings to be had if we make good decisions like using mental health courts and substance use courts to get folks out of the criminal justice system. And if we can divert them before they ever end up in the criminal justice system, how much of a savings could we have there? When we did our public hearings around the state, we had in almost every community a sheriff or somebody from the sheriff's department come to talk to us about the number of folks currently in our local county jails who really have a mental illness or need substance use treatment, and instead are being housed by us in jail, which is not cheap, which is not the right place for them when they really need treatment. And what the sheriffs told us was in most of our communities, it's between 25 and 30% of the populations they have on any given night that really need care and aren't, and don't need to be, incarcerated. When we went up to the UP, the Marquette County Sheriff told us in his community it's 80%. 80% of the people he has in his jail on any given night. And it's because we don't have any options. You didn't have a lot of close, safe facilities or places for people to go. So there's a lot of recommendations that take resources, and that's the next place we're starting. The governor gave us a little pot of money that we can use in this year's budget to start moving some of these forward. So some of the things I think that you'll see in quick order kind of in the budget, on the school side, we pledged some additional support for our school-based healthcare centers. So, and to make sure too that, so right now we have about 70 of them around the state, and about 61 of them have mental health care professionals as well as physical health. And what we found, there was Michigan State University did a 3-year longitudinal study on them, and found that in Michigan we do this really well. We actually draw down a lot of federal dollars to support the program. And what their study showed is that having that access to physical and mental health care in the school building had this tremendous effect on all of the students in the building, even those who didn't ever go to seek care. So absenteeism in the buildings went down. The general overall health went up. Instances of bullying went down. The openness of language to be willing to talk about anxiety and depression and the growing pains of all the stressors in life, they had a better language to do it, and they were doing it more often. And what part of the study showed, it's, kids talk to each other. So even if they're not the one going to get the treatment, knowing that they can get it and that it's safe is something that they all started to talk about. And so one of the recommendations will be expanding the number of school-based health centers that we have, and trying to get mental health care to be part of that in all of the buildings that we can have that be part of. We also will be doing, looking at how to make our special education funding in the state a little more flexible. So right now, once you have an IEP or you've got a diagnosis that puts you in that track, then it's covered. And right now our districts are saying they don't have enough flexible money to help those students at the first signs that something's wrong, right? And they might be students that are going through a transition. They have some anxiety or depression, but it's not necessarily something that's going to put them into special education for the rest of their school career. But right now they don't have a lot of early intervention money. They don't have a way to help them. And even districts that have school counselors or school social workers, their time really has to be dedicated right now because of the flow of the funding to only those students who have an IEP, or only those students who are Medicaid eligible. And what we really want to do is try to give them some flexibility. So that's something that will be coming quickly here too, I think. One of the other things that came up that was a real barrier to accessing care was Michigan has, just generally we have a healthcare provider shortage. I think you probably all know that. We struggle in a lot of places to have all the providers that we need. But psychiatrists in particular, in the state, what we heard in the testimony is in a lot of communities it can be 8 to 10 weeks before you can get in to see a psychiatrist. And for our, for our citizens that actually are going to need a prescription, hopefully in tandem with therapy and other treatment, and wanting that specialized, physician to give that prescription, it's a real barrier. And if somebody's in crisis, waiting for 8 or 10 weeks is not a good option, right? So we're going to increase the flexibility of our telemedicine statute. Right now we do allow for telemedicine in Michigan, but we don't have the ability to do it asynchronously. So right now it's the only way that you can bill for physicians' time who do want to use telemedicine. It can only be sort of live. They have to be consulting with the patient live. And what we're finding is that if we could make it billable and allowable for them to do asynchronous, so maybe it's an advanced practice nurse or a social worker or a PA or somebody who's with the patient, and then the psychiatrist can review the records, can then ask questions to the other healthcare provider and pass along the care, that we might be able to really increase the amount of people in the state who can get access to psychiatry. And what we're finding is that a lot of our general practice docs who end up being the overwhelming prescribers of a lot of medications, especially our psychotropic medications, a lot of our psychiatrists are saying they're pulling these people back off. Sometimes we're overprescribing, we're not prescribing the right things, and the more that we can get those, the sort of specialized physicians out there helping with prescriptions, I think the better off we'll be. So that will come pretty quick, and there'll also be funding to help expand some of those programs. We're already doing some around the state in partnership with our CMHs, like our local community health agencies, but we need to expand it, and part of it's the technology purchase. But it's getting, everything gets easier every year with technology, and now there's a HIPAA compliant iPad program that they can use to actually, so if you could have a case manager that, again, might be a social worker, might be an APRN, might be, somebody on the ground in one of our CMHs who has a HIPAA compliant iPad, who can do home visits maybe and go to where our patients are, or have them come into a local CMH without needing the full, cameras from the ceilings and on the TV, to just make it a lot more accessible. So we're kind of excited about that.
What does HIPAA compliant mean? HIPAA compliant iPad, meaning it has security?
It's got the security for the privacy, so that there's nothing else in there that's gonna record any of that information or capture any of that information, so that we just make sure it's everything we need for the privacy of the patients and their parents and folks who are involved. So
can you speak to the emergency clause in HIPAA?
Yep, and so that's another one that that came out of the work group conversations that we had, was this realization that our Michigan's mental health code was not in line with what the federal law allows for our, and we heard a couple of parents testify in particular about this. So there's this age gap in particular where maybe our young people are 18, 19 through 26, they're still in special education, they're still probably living at home and dependent on their parents, but they get to a point where they are an adult and they're legally allowed to have the right to refuse treatment, to talk about their treatment with their parents. And the federal law under HIPAA allows for a care provider to tell a parent or caregiver information that is in the best interest of their patient. So if it's something that they need to know to help guide their care and support their care, Michigan's mental health code didn't have that, doesn't have it yet. But we've got a bill, and that will be introduced, and I think the chair of health policy will be taking it up very quickly, to bring those two things in line. Because what some parents were telling us was, it's common for teenagers and their parents to, have a little struggle now and then, and particularly when you have young people who are also struggling with mental health, concerns. You really want parents, again, you want to respect, if you read the report you saw, we came together with this idea that our whole focus needed to be through the lens of doing everything we can to promote and empower all of the individuals that we're trying to help to be independent, to be self-determining, to make their own decisions. So we're not at all trying to take away that right of privacy or get in the way of that, but in those cases where their care and treatment could be guided better if their provider could tell their caretaker or their parent something that was specific and important for their for their best interest, we want to open up that possibility. And we're seeing that was a barrier for some. And with this, sometimes, especially for folks who need medication, it can be a struggle back and forth. They sometimes don't want to be compliant with their medication, and sometimes that's not the best for managing their diagnosis. So
years ago, when I first learned that one of the symptoms of schizophrenia is denial of the illness, that makes this a little complicated.
It does.
When somebody is psychotic and they're denying that they're ill, and then there are regulations in place to protect, it's states' rights issue too, but it can get very complicated, and I really thank you for doing what you're doing on that, because from a parent perspective, when your loved one needs help and you know, anything we can do to remove barriers to getting people help. And yes, there are parents, there are not so good parents too. So really the providers, you know, should be in the driver's seat as far as making those decisions and be protected to make those audibles about should I disclose or shouldn't I, as opposed to, well, it's just a black and white, can't do it.